Thank you very much, Mrs. Matcha, and to the IAS leadership for this outstanding opportunity to present to you on the global HIV pandemic. 20 years ago, I was honored with the Young Investigator Award at IAS 1996 in Vancouver. And it was a moment when I thought about how I had lost my PhD supervisor, Randy Coates, to HIV, and my best friend, all within a year. And it was at that moment that I dedicated my career to ending AIDS. I will now present to you on the state of the HIV pandemic. Where are we now? I was here, like many of you, at IAS 2000 in Durban. I remember being absolutely mesmerized watching Nelson Mandela, and tears were streaming down my face, and I looked to the woman beside me, a young school teacher from Zimbabwe, and she was crying too, and we held hands and shared a moment. I was equally struck by the personal account of Edwin Cameron, who spoke of the two South Africas, one with ARV access and one without. And when I arrived in Durban, far outside the city where I was staying, it was late at night and the restaurants were closed and I was looking for a place to eat. And a group of children came out of the bush and they were in bedraggled clothing and they were begging. And I said to them, if they could help me find a restaurant that was open, then we would all go to dinner. And all 20 of us sat down for hamburgers at the South African equivalent of McDonald's. And they taught me how to sing the South African national anthem. It was a moment I will never forget. And I often think back, where are those children now? Did some of them die? Did some of them acquire HIV? Or could maybe, just maybe, one of those children become a future leader of South Africa? I guess I will never know. But what we can do is look at South Africa and see how far it has come over the last 2 decades. There are some real lessons and some bright spots. In fact, the number of HIV-positive children has decreased by 76% since 2009, due in part to the precipitous decline in mother-to-child transmission, which is now 4%, and that actually meets the UN General Assembly's goal. South Africa's spectacular rollout of antiretroviral treatment means that there are now more people on antiretroviral treatment in this country than any other country in the world, 3.4 million. That's spectacular. But every week, 2,400 young adolescent girls and women become newly infected with HIV in this country. That is the highest incidence in this subpopulation in Sub-Saharan Africa. The lesson here is clear. We cannot simply treat our way out of this epidemic. And youth matter. This slide shows an age pyramids from 1950 versus 2050 for the rest of Sub-Saharan Africa versus Southern Africa. As you can see, Southern Africa looks very different than the rest of Sub-Saharan Africa, and by 2050 we will have what Debbie Burks from OGAC calls the youth bulge. I'm glad I'm too old for her to be talking about me. But seriously, what this means is that Southern Africa is going to have to double down on its HIV prevention efforts if it is going to achieve an AIDS-free generation. South Africa is actually facing twin epidemics, HIV and tuberculosis. This slide shows 100 years of TB case diagnoses for Cape Town versus New York and London. The first thing you notice is how Cape Town TB diagnoses dwarf that of the other two cities. And the TB case rates rise drastically when the HIV epidemic began in this country, reaching a peak of 800 per 100,000, which is just unbelievable. But this isn't just South Africa's problem, because 1 in every 3 AIDS-related deaths is attributable to tuberculosis. What about the rest of Sub-Saharan Africa? Well, this region continues to shoulder 2/3 of the global HIV burden. Since 2010, the number of people receiving antiretroviral treatment has doubled. And since we last met here in Durban in 2000, new HIV infections have plummeted by 41%, and AIDS-related deaths have dropped by 1/3. In 2015, we had some good news finally with respect to HIV incidence. Eastern and Southern Africa had a 4% decline in incidence. However, 1/4 of these new infections are among women aged 25 to 44, despite the fact that they comprise only 11% of the population. This topic will be addressed by the next two speakers. There is more room for an improvement, however. This slide from a recent review shows that high HIV prevalence mirrors low male circumcision prevalence, which is especially notable for Sub-Saharan Africa. We know that medical male circumcision can reduce HIV incidence, but the challenge is taking it to scale, and if we are successful in doing so, we could see further declines in HIV incidence at the population level. Turning now to Middle East and North Africa, this is a region with a very different epidemic profile. Here, the number of people living with HIV is about 230,000, or 0.1% of the general population. However, only 17% of people living with HIV and AIDS are receiving antiretroviral treatment. Like many other regions of the world, about 90% of the people living with HIV in this region are among key populations. And this figure shows HIV prevalence among men having sex with men in selected countries. As you can see, several of these countries where HIV prevalence is 5% or greater among men having sex with men are countries that criminalize homosexuality. More on that later. Globally, we now have 36.7 million people living with HIV/AIDS around the world. This is actually more than a few years ago because people are living with HIV longer due to the receipt of antiretroviral treatment. In fact, 17 million people are now receiving antiretroviral treatment, and that's about 46%. That is 2 million more people than the goal for 2015, and we have to just be spectacularly happy about that. True achievement. Congratulations. We've also seen a decline in AIDS-related deaths, 43% since 2003, but still we have almost 2 million people becoming newly infected with HIV every single year. We have so much more to do. Another bright light is mother-to-child transmission. At least 85 countries have virtually eliminated mother-to-child transmission. However, only about 1/3 of HIV-positive children are receiving antiretroviral treatment compared to 2/3 among pregnant women. Turning now to Eastern Europe and Central Asia, this is a region where 1.5 million people are living with HIV, but it is a region where HIV epidemics continue to expand. In fact, the HIV incidence has increased by 57% since 2010. And only 1 in 5 people in this region are living with HIV are receiving antiretroviral treatment. In fact, so many people are delayed in their diagnosis because they're migrants, they are refugees, they are internally displaced people. They are a key population that we have been missing. When we look more closely at Central Asia, we see a number of interesting findings. This is a region where injection drug use has been a prominent driver of the epidemic. However, in Kazakhstan and Uzbekistan, they have more mature epidemics now. So infections that originally occurred among injection drug users have spread to their sexual partners, and now in both of these countries, about half of the new infections are heterosexually acquired, as opposed to Kyrgyzstan and Tajikistan, which remain associated most closely with injection drug use. And in Turkmenistan, we still have no data. Turning now to key populations, this slide shows estimates of HIV incidence among female sex workers in Sub-Saharan Africa. What you note is wide variation between countries and even within countries, especially Kenya and South Africa. These are incidence rates. They're explosive, and in fact, HIV prevalence rates among sex workers are even higher. Here in Durban, it is believed that over half of the female sex workers are HIV positive. But it's not just who we count, it's how we count that matters. This slide shows the estimated contribution of unprotected sex work in 3 different epidemics, 2 in West Africa and 1 in East Africa. Now, if we take the classical epidemiologic approach to estimating population attributable fraction, we will underestimate the impact of sex work on these epidemics. However, if we take a different approach, that is dynamic transmission models that take into account ongoing transmission from sex workers to their clients and other sexual partners, we will have a different and a more dramatic impact of sex work on these epidemics. And it is even more dramatic if we project out into the future, such as 2033 is shown in this slide. But data quality matters too. A recent review by Sabin and colleagues found that less than 50% of lower and middle income countries have useful estimates of key populations. Shown in red are countries that have no data at all. How can these countries, many of whom are in Africa, how can they launch a successful HIV prevention response when they don't even know the denominator? But we don't just need to count people. We can also look to see what the virus is doing to have some insight into how the epidemic is spreading. This slide shows molecular surveillance of HIV in China nationwide since 2006. And it shows increasing HIV genetic diversity over time. In particular, a high proportion of circulating recombinant forms that differ between key populations. This is important not just for monitoring the epidemic, but also for vaccine development. But epidemiology fails if it continually tries to put people and pigeonhole them into boxes. And what it really can do is, unfortunately, conflate sexual identity with gender identity. One way of disentangling gender identity is the two-step method proposed by Reisner et al. First, to assess sex at birth, then to assess current gender identity, and then going on to assess sexual behavior. A very important read is the May issue of the Journal of Global Public Health that tries to unpack these issues and contextualize the underlying factors that underlie key populations: gender, sexual orientation, and culture. In particular, Perez-Brumer and colleagues suggest that we consider reflexive epidemiology that links social science critique with epidemiologic analyses. These fresh new approaches are necessary if we're going to truly understand key populations and what drives HIV risks among them. But there have been a number of transformations, if you will, since we last met at the International AIDS Conference and where transgender persons finally took the spotlight. We have, from the National Institute of Health, funded 2 new behavioral intervention studies, the first of their kind among trans women. At this conference, new comprehensive guidelines for HIV and STI testing and treatment will be launched for transgender people. And in the United States, we now have a National Transgender HIV Testing Day. These initiatives were planned not just for transgender persons, but with transgender persons. Now that's progress. But it's not all good news for other sexual minorities. This slide shows HIV diagnoses among men having sex with men by age. As you can see, in the older age groups, we have relatively flat lines. However, for the 2 youngest age groups, we have increasing numbers of HIV diagnoses. In fact, in the 25 to 34-year-old age group, we see a 27% increase. Looking more closely at the youngest age group, 13 to 24, and examining the race and ethnic composition of this subgroup, we see that over half are among African American MSM and 1/4 are among Hispanics. These rates rival what the earliest, darkest days of the 1980s has shown us. And in fact, if we put this into a global context, these are data coming from the Lancet series of HIV among men having sex with men. We see that the HIV incidence among young African American men in the United States is among the highest in the world. What can we do? Well, we can think about interventions that will reach these populations, and this slide shows the cost effectiveness of pre-exposure prophylaxis, or PrEP, for men having sex with men versus people who inject drugs in the United States. Cost effectiveness here is measured by quality adjusted life years, or QALYs, plotted against incremental costs in billions. There are 3 take-home messages from this slide. The first is that PrEP is cost-effective for the 20% riskiest men having sex with men in the US, but it's not cost-effective for all MSM. A recent paper showed that PrEP is not cost-effective for people who inject drugs, and this is due in part to the high cost of Truvada. In fact, there's a linear relationship here between cost-effectiveness and cost. So if the cost of Truvada was decreased by 50%, the cost-effectiveness would increase by 50%. What this means is the cost must go down. Now, the third take-home message from this slide is that the cost-effectiveness of needle exchange programs for people who inject drugs is wonderful. It's extremely wonderful. And yet we have not taken this intervention to scale. So it's important to keep in mind that while PrEP should be scaled up, assuming that it can be cost-effective, it should never be done so at the expense of interventions that we have known have worked for decades and are much more cost-effective. Now let's take the last few minutes and reflect on past international AIDS conferences, because we're not just standing up here saying empty words. We need to hold ourselves accountable. So at IAS 2008, Dr. Adiba Kamal-Zaman said, treatment for substance abuse is HIV prevention. Is the world taking notice? Well, not nearly enough. This slide from the recent Lancet series published in March shows coverage of drug-dependent services by region and shows that for the most cost-effective programs, opioid substitution therapy, so methadone maintenance or buprenorphine maintenance, that coverage is only high in Europe. It's much lower in Asia and the Americas and almost virtually absent in Africa. Now, why does this matter? Because HIV outbreaks among people who inject drugs can occur extremely rapidly, with recent examples in Greece and Romania, and even in rural Indiana in the United States that had only seen a handful of cases in the year compared to like 200 in 5 months. And let's not forget that in Africa, we have 20 countries that actually report injection drug use, and among them, there's several that HIV is now very well established. This slide shows that within 5 years of beginning to inject drugs, that HIV prevalence approaches 20% in Nairobi and in the coast. And Kurth and colleagues found that of HIV-positive people who inject drugs in these regions, less than 5% are virally suppressed. Now, Kenya is to be congratulated for implementing both needle exchange and methadone maintenance in recent years, but it is going to need to scale these up dramatically and to expand antiretroviral treatment to people who inject drugs if it's going to reverse these trends. Now let's turn to see the lower and middle income countries that have the highest antiretroviral treatment coverage. What's great about this is that 5 of these countries are in Sub-Saharan Africa. However, many of them are dependent on sustained support from the Global Fund, which may not be tenable. In the 10th place here is Mexico at nearly 50%. But what's interesting is that this masks regional trends in the border. Now, this slide gives this example by showing the HIV care cascade for HIV-affected populations in Tijuana, which is on the Mexico-US border in the north. And using data from my own team, Dr. Laramie Smith found that of nearly 200 people who are living with HIV, that only 48% had ever been tested, only 11% knew their status, 11% were linked to care, and less than 5% were receiving antiretroviral treatment. So contrast this to the 50% coverage that we had seen nationwide. Mexico is not unique in this respect. Let's turn now to the lower and middle income countries with the lowest antiretroviral treatment coverage. What's interesting here is that 5 of these countries are also in Sub-Saharan Africa. And yet when you look at this, what struck me is that many of these countries have experienced war and armed conflict, coup d'etat, natural disasters, famine. HIV is just one of many problems that these countries are facing. So what this really means is that we need to engage new partners in the fight against HIV, those in the public security sector and those in the economic sector, as Nelson Mandela told us so eloquently 16 years ago. Let's reflect now 20 years ago to IAS 1996, where the late, great Jonathan Mann said, "To uproot this epidemic, it will be necessary to deal with its root societal causes, namely a lack of respect for human rights." How right he was. Well, what have we done? Well, of the 77 countries that still criminalize homosexuality in this world, 34 of them are in Africa. And in fact, in Nigeria, where homosexuality is punishable by death, Schwartz and colleagues examined the impact of new anti-homosexuality laws that were implemented in 2014. And when they asked men having sex with men their perceptions before and after the law, they found that many of these men were now fearful of accessing treatment or going to gay venues. They were also more likely to be harassed or to be blackmailed. Now, this is a country where HIV prevalence is 45% among men having sex with men, and HIV incidence is 14%. This is not just a tragedy, this is a disgrace. At IAS 2006, our current IAS president, Chris Byer, said, "HIV risks are at the individual level, but their drivers are structural." In fact, Charlize Theron said the exact same thing yesterday. What do we mean by structural? Well, this schematic shows the HIV risk environment and proposes that structural factors are those that are exogenous to the individual, and they interplay with host and viral factors. They operate at different levels, macro, micro, and there are different types: physical, social, economic, policy. In fact, even molecular biology is now showing that structural factors matter. Just last month, a paper was published that was tracking HIV-1 subtype B spread since the beginning of the epidemic. And it found that transmission patterns actually follow geopolitical factors such as migration, tourism, and trade. They also found that most of the HIV infections originated in North America and spread to Western Europe and other parts of the world, as opposed to the other way around. Sorry, Donald Trump. These authors concluded that HIV prevention efforts need to be global in nature, and they need to take into account macro structural factors, the political and economic level. So this begs the question, can we reverse HIV epidemics with criminal justice and policing reforms? The data suggests that yes, we can. This slide, which comes from the most recent HIV and Lancet series on HIV in prisons, was a modeling scenario exercise on the impact of incarceration on HIV among people who inject drugs in Ukraine. And in the first scenario, it was where we see here that if incarceration had no impact on HIV incidence, that we would have averted up to 55% of HIV incident infections. But if we stopped incarcerating people who use drugs, going forward, we would only eliminate about 12% of incident infections because of the past impact that incarceration has on those already imprisoned. So these authors, Altice and colleagues, found that if we were to implement opiate agonist treatment, again, methadone maintenance and buprenorphine in prison, and to continue it post-release, that we could reduce up to 20% of HIV infections over the next 5 years among people who inject drugs. So other than policy reforms, we have a number of challenges going forward when we think to the future. The lack of donor commitment to the Global Fund threatens the sustainability of the recent advances that I've described earlier. In the United States, the National Institute of Health has abandoned its 10% set-aside funding for HIV research and recently reprioritized HIV research funding to focus almost exclusively on biomedical aspects at the expense of social and behavioral sciences. In Brazil, which was the first lower and middle income country to provide free antiretroviral treatment to all medically eligible people living with HIV, recent political transitions are going to unravel it all. We cannot afford to let this happen. So what do we do? Well, a final reflection comes from Greg Gonsalves, who at IAS 2006 said, "We need to reinscribe the fight against AIDS as part of a larger movement for social and economic justice." I agree with him. So now close your eyes. Imagine 10 years from now, it'll be IAS 2026. Some of you, the younger ones, will be sitting in that audience looking back at this moment today. Will this be seen as a moment where we turn the tide against HIV, or will it be seen as yet another missed opportunity? It's up to us. Collectively, we need to hold ourselves accountable. So as you go and experience the conference this week, don't just watch, see. Don't just listen, hear. Don't just think, act. And it's not too late to act up, because silence still equals death. And if we have learned anything from the history of South Africa, it is that there is a secret hidden activist in all of us. We just need to channel it. So I'd like to thank a number of people that shared their ideas, their thoughts, their images. And I would especially like to thank Through Positive Eyes, a global exhibition to banish HIV stigma. Many of the images shared today were taken with cameras by HIV-positive people who are sharing their stories with you and with me and the world. Thank them for their courage, and go and see their photo exhibit at the Durban AIDS Art Gallery. Thank you.